Thank you. So, you heard Sean Standard's talk on femoral lengthening. So basically, there's nothing I would need to add. So I would just go again. But yeah, still I want to show you there are different ways of doing things, and I just want to show you our experience with femoral lengthening for congenital short femur. So if you think of our treatment algorithm, we start lengthening earliest around the age of 3 to 4 years for a couple of reasons. One reason is the size of the femur. The other reason is especially that all the severe CFD cases usually need a super hip. So this is about the time we start to do this. And let me walk you just through a case which is a case that was treated a very long time ago. And this is Yasmin. She was 3 years. At that point, she had her first lengthening when the leg length discrepancy was 6 centimeters. It was calculated to be 12.3 centimeters at maturity, which is a very doable discrepancy. If you look at the X-ray, you could appreciate that maybe the coverage is not so hot. So if you would measure the CE in this case, it would be definitely less than 20. So in fact, this would be a case where you want to do something on the acetabulum side before you do any lengthening. But this was a long time ago, so the first step in this procedure was to do a femoral lengthening. The knee was bridged with rigid hinges. And you can see this was still in Lusarov lengthening. The lengthening went well. The hip was quite fine, so no problems here. The frame was removed, and this was very typical. The regenerate fractured. So then she had, because she was in this circular frame for some time, so the idea was just to give her a unilateral frame because that's maybe a little bit less of a nuance. But one thing you can already appreciate, there is some procovadum, and if you look at the knee doesn't look very super happy, so it's maybe there is some extension deficit. So nevertheless, she healed. She was still in a little bit of this deformity, and everything was fine. I'm sorry for the quality of the X-rays; those are really old X-rays, so that's why it looks like this. So at the age of 5 years, and if you look back at this, you can maybe appreciate that it's even more like on the edge as it was before. And so at the age of 5 years, she had a Pemberton and a derotation of the proximal femur. And at the age of 10 years, which was I think around 2009, something like this, she had 5 centimeter shortening again. At that time, the approach was like a little bit more advanced already. At least we did a trauma cut analysis. Then we did a TSF frame for her lengthening. And you can see this is during her lengthening. Quite nice regenerate. And so the way we are doing this, if we use a circular frame, we use two two-thirds rings. And we put the two-thirds rings in a way that there is like on the proximal ring, the opening on the posterior medial aspect, because that makes it easier for sitting and for walking. And for knee flexion, we do have an opening on the posterior aspect of the knee. The rotation of this is a little bit more complicated if you think about your master tap and if you think about the rotation of the frame. And there were a couple of things to consider, like external rotation of the ring, being 60 degrees in those cases. You will see in my lecture tomorrow that this is no longer a real big issue with the new software, but nevertheless, these were things we needed to consider. So this was her frame. At that time, she had a flexible bridging of the knee joint, so we made sure that she can flex the knee during lengthening, and we did the lengthening and the valgus correction, and she had a nice result with a good lengthening here. So at the age of 12 years, we did a contralateral epiphysiodesis. We did a canali procedure to make sure that that's what she has and that the leg length discrepancy doesn't get any longer. Nevertheless, with around the age of 13 years, she presented with pain at the ankle joint. And so as we said before, there's like no CFD without a little bit of fib hemi and the other way around. So you can see in this case, there was quite a severe valgus at the ankle joint, like a 14-degree ankle valgus. again, trauma cut planning, and you know, I was very focused on the lines and focused on having the perfect correction. So at that time, I thought it's a good idea to do this with a frame, but then use a plate to fix it. Of course, I think there are much easier ways to do this, but yeah, at that time it was a nice idea, and it worked very nicely. She had a good alignment, and she had a nicely like an equal leg length. But you can still appreciate, if you look at this picture, this is her at the age of 14. She still has about 5 to 10 degrees of knee extension deficit, not passively but actively. So it just shows you, if you mess up somewhere down the road, it's very difficult to correct it again. So this is why we try to be better. And so this was another case where we did a CFD lengthening in an underlying Conradi-Hünermann syndrome, which I think is quite rare. We did the first lengthening at the age of 7 years, when the leg length discrepancy was 4 centimeters. And you can see the first program we did was 3 centimeters short, and we corrected the 8 degrees of valgus deformity. And you can see this is day 4, this is day 32, and at the end of the first program, I checked the axis and I made sure that I get some more lengthening, of course, but that I also get a good alignment. And when I mean alignment, of course I mean the mechanical axis, but you also want to look at the anatomic axis. Why? Because now we know we have this 26% refracture rate. And a very easy and nice way to prevent this is the clinical picture, is to bring in a rush pin. Of course, with the knee fixed, it was still a little bit cumbersome, but at the end, we opened up the knee so that she could walk with a knee flexion, and we just fixed it for the night in full extension. And then at the time of the frame removal, I put in a rush pin to make sure that there will be no refracture. So time in frame was 5 months, and of course there was no fracture of the regenerate. So I think this is one of the things we learned. I always put in a rush pin in a femur whenever I remove the frame in CFD to prevent refracture. And I think it's a very important point, and it also makes your clinic very easy because you don't have to get up and treat the fracture. Now, what's our current technique? Our current technique, this is a young man I treated for CFD. You can see there is a little bit of a there's a little bit reduced CCD angle. There is a retrotorsion on the proximal femur. In this case, I did a TSF lengthening again, and this is the fixation for the distal femur. Proximal femur, I did an acute derotation and just fixed it to the proximal ring, which is a nice acute correction you can do, and you can also correct a little bit of the varus in this case. And then again, very important, you want to maintain this knee range of motion. So you can see you can very easily build a knee hinge, and the knee hinge in full extension, in flexion, and you can really get these children to work on their knee range of motion very nicely. This is the frame. Of course, you can again argue it's quite a big frame compared to a unilateral frame, but I think there are advantages and disadvantages. I think the big advantage of the unilateral frame is for physical therapy. Why? Because the child can lie flat, like on the tummy, and this is much easier for the range of motion exercises. The other thing is, of course, with sitting in the wheelchair, lying in bed, you're always a little bit in a flexed position in the hip and also in a flexed position in the knee with a frame, which is also a big advantage of the unilateral frame. The advantage of the 6-axis frame is that you can get the axis perfect, and that you can make sure that at the end of correction, and this is what you can see here, it's a nearly 6 centimeter lengthening, and at the end you can make sure that you really get a straight position of the bone in the AP and in the lateral view, because you want to be sure, this is the lateral view, that again you can fix this with a rush pin nice and easily. You can see the knee hinge, full extension, and this is the rush pin. Frame was on for 5.7 months, and there is a very nice paper looking at this refracture rate in CFD after frame removal, and they reported a rate of 34%. So putting this rush pin is really important because it basically reduces this rate to 0. Now, of course, now we have different techniques than before. We have lengthening nails. Why is this now a good option? We have nail designs that you can insert from an antiquated approach, and you have smaller nails that go down to a diameter of 8.5 millimeters. So this really makes it now possible to treat children and adolescents. So, and this also gives us the opportunity to split up lengthenings. So sometimes, in some cases, if you have a predicted leg length discrepancy of 6 centimeters, this would be a rather big lengthening. So if you wait till the end of growth and then you do 6 centimeters with a nail in a CFD case with maybe unstable knee joint, it's something which will work with good physical therapy, but that's something that can be tricky. Now, if you split it up in 2 lengthenings, then it's really, really easy. And so this family decided that they don't want to have the child use a 6 centimeter shoe lift till he is like 14, 16 years old, and then do the lengthening. So we decided together to do lengthening before high school. So a 2.5, 3 centimeter lengthening before. I also corrected the Procovadung in these cases because, sometimes you also have to appreciate the lateral view X-ray. If you have a big Procovadung, you need to do the osteotomy at the apex of this deformity. And you can see, in this case, it was a precise stride nail. So this was before the stride nail was recognized to cause some irritation at the male-female junction. So this patient was doing full weight bearing 1 week after surgery and was just running around through his whole lengthening and didn't really realize that he had his leg lengthened. So this was, of course, very nice and easy, and we'll remove the nail and he will have a second lengthening at the end of growth for another 3 centimeters. Now, of course, we can wait till the end of growth, but then it's very important. If you see these patients regularly, you need to think about lengthening using a precise nail. So make sure that towards the end of growth, you use a guided growth to bring them with the mechanical axis in 0 or even a little bit medial, like 6 millimeters medial, 7 millimeters medial, so that you can use like the antiquated approach to lengthening along the anatomic axis and that you end up with a nice mechanical axis. And this was a 16-year-old. He had a previous triple osteotomy. He had a previous frame lengthening. Then in the end, we made sure to do guided growth to get the axis right, and we used a precise nail for a 5 centimeter lengthening. He was full weight bearing after 4 months and had a nice result. Very important in those cases, you need to cut the fascia lata. You heard it before, it's the enemy of lengthening, and especially in like young men with very tight fascias, that's extremely important. Sometimes we missed the guided growth or the patient comes late, then we have to deal with some deformity, like in this case, valgus deformity, mild CFD, and shortening. So in a case like this, we can come from retrograde because the physis is closed, and we can do a reverse planning. So we use this reverse planning method that was introduced by Rainer Baumgart, and then collapse back the femur to the starting point. We take this starting point picture to the OR, and we create a situation to exactly mimic our preoperative planning. We mark the osteotomy, and we only ream to the osteotomy. We then do the correction with an X-fix on the lateral side with 1 pin posterior to the reaming and 1 proximal to the nail. And then you can see we have these protection sleeves, which are a very nice tool to make sure that all these reamings do not go into the joint, and also at the same time to really guide our direction. So you can see we ream to the osteotomy, we correct the deformity, we keep on reaming, we can fix it. We also have a grid. We have a grid like this on the table to make sure that we can check the alignment. Then we insert the nail, and then we lock. This is the grid. You can see there is this double line, so that's where we want to end up with our mechanical axis. We can check this while the patient is on the table. And then very important, you have to use blocking screws. Blocking screws are super important to prevent malalignment during lengthening and to keep your nail or your train on track. And the other very important thing, if you do lengthening for CFD, think about the knee joint. You will need to use some KAFO to make sure to, again, brace in full extension for the night to make sure that there is no knee subluxation or dislocation. This was at the end of lengthening with a good mechanical axis, no procovadum during lengthening. And sometimes if you do this, maybe because you manipulate the osteotomy on the lateral side, you do get a little bit of delayed healing here. But this is very easy with the nail. You can just sit it out. So there's nothing you need to do. It will just come eventually, and then you remove the nail. Another case like this, you can see we did guided growth. It seems this was too late, and quite a severe valgus deformity. And same technique. We removed the guided growth plates, and here you can see this is again the half pin for the X-fix. In this case, you can very nicely see we mark the osteotomy, so we know how far we have to ream. This is the reamer. This is like one of the reamers. We then do the correction. We keep on reaming. We put in our nail in the corrected position, put in blocking screws, and then we do the lengthening. And this was 2 months after surgery. And the patient healed very nicely, also with a good mechanical axis. The nail was removed 2.5 years after surgery. So in summary, I think for all these cases, no matter what frame you use, I think the most, or what frame or what technique you use, even if you use a lengthening nail, the most important thing is to protect the joints. And to protect the joints, it's important to do preparatory surgery, use braces, hinge the joints in case you use an external fixation, and of course the most important thing is physical therapy. Sometimes less is more, so I think especially with nail lengthenings that are quite easy for the patient, it makes sense to go for 2 smaller lengthenings instead of 1 big heroic lengthening. And I think this rodding of the femur after removal of the frame is a very important point, because it really saves you and the patient a lot of trouble. Thank you.
Questions? Christof, why are you using a circular frame, not monolateral?
So for me, the biggest reason is that I can make sure that at the end of lengthening, the bone is in the perfect position regarding the axis, so the alignment. Regarding, I don't want to have any procovadum during lengthening, or sometimes I want to correct some procovadum. And the other big advantage is that you can really place this rush pin very nicely. You can use a big rush pin. You don't have to use some small rush pin that you maybe have to bend a little bit to come across something. So you can have a solid rush pin that really prevents fractures. Actually, the fracture rate with this technique and with the big rush pins for us is 0. Yeah.
I understand. It's much more forgiving. Yes.
It's more forgiving. Yeah.
And you can play, if something wrong, you can still correct the deformity.
Yeah.
Which is monolateral, it's very difficult to do. Thank you.
We all agree that the precise nail changed the way that we treat all this lengthening distribution, especially with the femur. And we not avoid, but we do femoral frames less and less. And my question is, when do you wait and say to the parent, okay, I will do lengthening with a precise nail at the age of 8 for the first, or when you say, okay, I will do the lengthening with the frame with all the complications that we're all familiar with at the age of 4 or at the age of 5?
I mean, I think one thing is if you know about the complications, you can prevent most of those complications we show. So I think you can do a safe lengthening with a frame if you bridge the knee, if you make sure your hip is well covered, and if you make sure that you prevent refracture. I think if you think about these 3 things, I think the lengthening is very safe and reliable procedure. For me, it's mostly about the predicted leg length discrepancy. I don't think it makes sense to wait till the leg length discrepancy is like 13 centimeters and then say, and now we correct everything with nails. especially not if you have joints that are not stable. Because I think we need to be aware, especially for CFD, we still need to protect those joints. And to go for a very big lengthening, I don't think it makes sense. So usually we want to do the first lengthening when we have 5 to 6 centimeters, so that we know we can catch up again, and then the next step you can do with a frame. But of course, if you have a fibular hemimelia or something, then of course you wait with the, in combination with CFD, then it can make sense to wait a little bit, do first the tibial lengthening with a frame, and then later on deal with the femur and do like a precise lengthening, yes. Mm-hmm.
I have 2 questions. One is for the polar screws. Do you use polar screws in sagittal plane to prevent much different uniformities, especially with the retrograde nails? Do you find it useful? And the second question, do you have an experience of lengthening femoral over nail, like Duval nail, instead of changing for the nail later on?
For the first question, we do use blocking screws in the sagittal plane for tibias, not really for the femur. So it makes a lot of sense, especially if you do a very distal osteotomy for a retrograde nail. And I do it if I need to correct the deformity. If I have a flexion deformity and I want to correct it, then I use a sagittal plane blocking screw, but usually we don't. The reason is usually you're very close with your nail to the cortex, so there's very little room for going into procavatum. It's always a question of the nail diameter to the intramedullary canal diameter. So the bigger your nail and the smaller your canal, so the better the fit is, the less possibility or the less risk there is of any malalignment during lengthening. And I think in the distal femur, usually we do the osteotomy about 7 to 8 centimeters from the joint line. It's reasonable enough, and from the entry point, you're quite anterior, close to the anterior cortex. So we don't really see any procavatum here, or we haven't had problem with this as far as I can tell you. For the second question, I have no experience with the extramedullary lengthening with precise. I've not done this yet. I'm still considering. Excuse me?
But with an external fixator.
Okay. The problem is if you do this in the femur, it's a little bit difficult because you come from proximal with the intramedullary fixation, and then you lengthen distally, usually. So.
But using the telescopic nail, like the Duval nail.
This Duval nail for me would not be. You have 2 problems. So one problem is there is still a small canal, so you still have to fix your pin somewhere, and the other problem is that the Duval is quite thin because you have the male and the female part, and the male part gets pretty small.
It's not strong enough to prevent.
Yeah, and I can't think that there is any advantage compared to removing the frame and bringing in a rush pin, which is, I think, more stable, less prone to complications, and I think the easier way of doing it. But it's, of course, it's an interesting idea from the lengthening over nail perspective. Yes.
Thank you.
Thanks. Yes.
Do you usually do ideally tibial band precision for any lengthening, or?
Yes, absolutely. Yes.
Doesn't matter even if you do 2-3 centimeters?
Yeah, I think of course, it's something you need to consider. If you do 2 or 3 centimeters, maybe it's not such a. I think you can do without. But if you go up to 4, 5, 6 centimeters, you definitely need to do it, and you definitely want to do it in CFD cases, because the IT band is one of the reasons why you lose. When you lose knee extension, the ITB band really starts to subluxate your tibia. So you definitely want to cut it for all of those cases. Yeah.
I definitely encourage you to ask questions. We have time.